This is Sg2 Perspectives, a weekly conversation between the Sg2 intelligence team and industry thought leaders about the biggest trends in healthcare. We're happy you joined us today. Enjoy the episode.
The business model is broken. We know that. We know things are very risky over the next several years. We'll have a choice of band-aiding, duct taping, piecing it together with bubblegum. Those are the things that we often do in this industry. Or we have a choice to be bold and to try something different and commit to some of these long-term aspirations to differentiate yourself in the market.
Welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. I have my two close colleagues, Rebecca Limestall, Brian Esser, with me because this group, like me, is on the road pretty often. We get the privilege of working with health system, senior leadership teams, strategy teams, boards. Spring and fall are kind of the busy board activity season. We've all been in different places for the last couple months, and I was really anxious to hear if they're hearing some of the same patterns that I am. This idea that systems have a synced up vision for where they're going to need to go and the forces that are creating hurdles for them to continue in the status quo. Most are in pretty similar agreement. They're going to have to change pretty dramatically. And they're synced up on the ways in which they're going to have to do that in terms of their footprint, reimbursement structure, all these pieces, they see the fundamentals. But then short-term priorities aren't matching, moving towards that vision. Even though this isn't like a 30 years down the road vision, it's very much a 3 to 5 years. I can't help but keep pulling on that thread. The vision's pretty aligned. Inpatient's not making enough margin. Our footprint needs to diversify and be less hospital-centric. Pharmacy growth right now is so essential, but we also see that as one of the biggest structural weaknesses and we're least certain about long-term. CEO's message to the boards and leadership teams has often used some of those code words around how big the change is going to have to be really efficient. Even when we've seen the last few years, big gains like length of stay, expenses, workforce, talking about tough choices, saying no to some things. Weighing those two things together, there's a disconnect between the big things that are on the table long-term and the short-term priorities. I don't know if you're feeling the same balance of priorities versus capabilities. I'm not hearing an uncertainty around can we deliver on this level of change. I'm just seeing a disconnect between the things systems are working on, what's on their plan today, and where they need to go long-term. Rebecca, what do you think?
Interpreting this idea as variation in urgency as I go on site with different members. This concept of how urgent is the burning platform? What's the tone? What's the vibe? What is it we're trying to go for? And there's some organizations who are like, we have got to make some tough decisions. We need to question our assumptions. We need to move forward and we need your help preparing for that. Others have a much more paced approach and less urgency, which makes me a bit nervous, to be honest, in this time we're in right now. One CEO that I talked to, his phrase that he has said over and over to his team is, we need to be ready for 2028 by the end of 26. And that's probably the most concise way that I've heard folks talking about urgency. But it's come up in other ways too. I'll have CEOs stand up in a board meeting as I present the insurance coverage forecast and share deterioration of the payer mix for their community and what that means for their financials and for the future state of the organization. A lot more partnerships on the table, but high variation in the urgency in different boardrooms across the country.
Urgency, that's a word that makes a lot of sense right now. And I've even seen it showing up in pretty favorable markets. We have a window to take advantage of the fact that we're maybe in slightly better shape than others, but we have to invest and not have our team say, hey, we're doing great. We can keep doing things the same way. Brian, what are you seeing and hearing?
The urgency is definitely out there. There is an acceptance that the quality of revenue is not going to hold up over the next several years. We see that playing out in different pockets. Rebecca, you mentioned the insurance coverage. So the most obvious ones are the Medicaid market and the exchange market, which are hitting first and quickest across the states, but in a variable way. That is going to be a local nuance. When I talk to the CFOs, they're saying, yeah, we can model that segment of the business out. And they're really keeping an eye 2 to 3 years down the road, 2030 being this inflection point where two things happen. You have the aging of the full baby boomers into Medicare. And then that is also when the majority of HR1 starts to hit on a go-forward basis. These two things coalescing around the 2030 date means we at least have a date and we know what is coming and we can plan for it, but it also ups the anxiety across the organizations. This idea of this is where we're at, and then operationally, what do we need to do to meet that moment? Trevor, you mentioned these code words of efficiency, operational excellence, all really focused on how do we sustain a positive margin. The organizations I'm talking to, I live in Ohio. So in rural Ohio, we had a meeting with the community health center, also with some of the academics and some of the highest growth markets in the country, all saying equal things of length of stay still really matters. We need to focus and double down there, make sure we're reducing variability in a very meaningful way, and make sure when we say fulfill our mission, what does that actually mean? Especially for our stronger organizations, you're going to be getting a lot of calls from potential partners. Rebecca, I know you're working on this, distressed assets in the next coming years. How broad is your mission? And can you actually fulfill that? And how do you game plan?
On the flip side, I have seen organizations use this as an opportunity to test their assumptions with their boards. Many of the small independent hospitals are independent or bust via their board, but they're starting to change their perspective about being responsible for the community and access and economics, and less about the hospital itself. What we're seeing with that is an openness to partnerships that we may not have seen in the past.
Ambulatory first is a theme we've been pushing with our members, but it had kind of a weird life cycle. It went from at first, help us define this. What are you guys talking about? And really quickly, it became mainstream. It's one of the places where our members sometimes steal our vocab and then start using it. We went from having to describe the definition and convincing people to everyone was on board pretty quickly. Systems now, a year or 18 months after we've introduced this concept, are saying, oh yeah, here's how we've totally changed the way we're prioritizing projects, the way we're thinking about growth, the way we're thinking about our footprint. I'll argue against myself. Systems are viewing partnerships as the lens to grow quickly off their hospital campus. That's one place that's moving this direction. Pharmacy's never been bigger on a CSO's radar. Everyone's working on access, but just opening access isn't quite ambulatory first planning. You're not growing something new. You're just helping more patients get in the door. Do you see this as one of those areas of disconnect where the long-term vision and the short-term priorities aren't quite aligning?
This is probably the epitome of the cognitive dissonance. Organizations know it's important. They know our business model itself is not going to work into the future, and we need to be ambulatory first, being able to make a profit, our margin on the outpatient side, being able to connect with patients and what they're looking for of seamless care. But very few are doing it. And I go back to a quote from a chief strategy officer a couple of years ago when I asked them, well, how much of your time is spent on ambulatory work? She said, well, do you mean work or how much time I talk about it? Because I talk about it 80% of the time, but very little of the capital, less than 20% of the capital decision-making and efforts are going into the ambulatory side in reality. We're still there in a lot of ways. This is also a topic that's universal regardless of organization type. I hear it in rural markets, within AMCs and children's hospitals, and I hear it in IDNs, whether large or small. This concept of knowing we need to change how we do business is there, but we're still taking little steps to get there. I had a CEO who shared with me a couple of very specific steps that they were going to do. They'll start with the ambulatory data instead of sharing and talking about the hospital first. They had a tradition of never getting to the ambulatory part when they were going through their meeting. The other is a switch on what's on their dashboards, what's most important. And then she admitted, looking around the room, that many of the people in the room, which was her executive leadership team, were very inpatient focused. And maybe there was time for either shifting of roles or bringing more people into the conversation.
Just the simple things of saying, let's talk ambulatory first in the meeting. Let's actually elevate this to a topic, if that's going to be our area of focus, to be top of mind. On the ambulatory side, we're trying to extend the way we operate into an ambulatory environment and even take service lines. We're having this interesting internal debate right now. The service line operational structure built initially around an acute care chassis and offering made 100% logical sense. And Sg2 stands by that way we put it out there in the market. But the further you get away into this ambulatory setting, into a place where you have consumers and disruptors and payers all acting in their own self-interest, which makes sense, and pushing and challenging us and sidestepping us if it's not meaningful enough to them in their decision-making, puts a lot of pressure on how do we actually get that entire ambulatory system to orchestrate in an effective manner? And how do we make sure the on-ramps to the service lines we've already created are fluid and seamless? And then how do we mix and match the assets, whether they be brick and mortar or virtual or retail, in a concerted way that actually meets the patient where they need to be? That's the tough part of ambulatory in my mind. The strategy need to lean into HR and say the workforce for ambulatory should look and feel different than in the hospital. Have we staffed an ambulatory workforce with inpatient folks that don't want to work in the hospital any longer? Or are we building an ambulatory first workforce? That's two different mentalities. Right now, it feels like we're being a bit reactive on the workforce dynamic in the ambulatory setting. And can we get a bit more proactive in designing in a future focused way?
Smart thoughts. Good takes from both of you. Are you seeing capital planning evolve, move, shift to try and focus on prioritizing things that will position future growth? People feel reactive right now. There's things that have to get done. Money is expensive. People are still borrowing, though. Are you seeing the capital planning process as a lens through which systems are telling us what their priorities are?
Folks would like to see it shift. Capital continues to be focused on the most capital intense sector, which is the acute side. A lot of our stuff just goes to maintaining that infrastructure, and that's where we're spending it. From the strategic capital deployment side, yes, ambulatory pharmacy is where a lot of folks are putting those bets today. And we see that with some of the acquisitions or other build outs across the country, areas like ambulatory surgery centers, ASCs, urgent care, trying to understand where is the most ROI and how do we reduce the friction or make it easier to steer patients into the ecosystem we want them to be in. Capital is expensive. It's likely to go where it's most needed, but we do expect from a strategic point of view and deployment to be shifting more towards ambulatory in a meaningful way.
In my conversations with clients, the capital planning process, strategic financial process, all these different processes that we go through to get funding. Organizations are trying to get a better grasp of what's needed when and how to pace that financial planning over time. This comes up a lot in our conversations with organizations about operating model and includes structure, who makes decisions, how do we move forward with financial decisions. Gone are the days of the one-off ideas, and we're seeing a lot more rigor being put into all financial decisions.
What both of you outlined is pretty similar to what I've heard and seen. Some systems have made more progress here than I expected in the last couple of years. There's still all the hurdles that have always been there around internal politics, hospital-based leadership, etc. I heard a recent quote, "It's easier to just close a service than redesign it." Now, that's coming from someone who knows better than me, who's working, running, living, operating a big region of a health system. But at the same time, this is a market that's ripe to think about how to distribute services and to view a piece of this as a hub. And they have control over the spokes. They kind of own the whole market. Some systems are going to use service distribution as a place to differentiate themselves. It could help dramatically in recruiting, contracting. Strategically, systems have to be good at saying no to some things. At the same time, huge distribution in terms of how systems think they can make an impact. Do you see this as a place that is getting some traction, or is it another place, the wish, the dream, the desire, the volume quality relationship that we've been showing people for a long time still might not move the needle?
We need to be taking those discussions more seriously within health systems. And I am seeing organizations make that call, make those tough decisions of what to close, what to consolidate, which services they truly offer. I'm spending a lot of time with children's hospitals these days. There's a couple of big themes that are going on that are impacting care delivery. One is a declining birth rate across the country. Two is considerations around vaccine hesitancy, as well as how the adoption of the new RSV vaccine impacts volumes. The reason why I bring that up is the service distribution decision looks a little bit different for these standalone children's hospitals. And it looks a lot more like partnerships of supporting some organizations where their OB NICU program may not be doing as well as they would like. We see some partnerships at that OB NICU level to help with that OB pipeline for children's hospitals. We're also seeing a little bit more of what can be taken care of out in the community and some partnerships related to that within children's hospitals. And there's much more of an appetite for that than there was in the past. That flavor of service distribution looks a little different for the kids' hospitals. Oftentimes they're the one responding to the decisions of other organizations, but it is real and we are seeing a lot more of those discussions occurring.
There is a movement in pockets, organizations making deliberate service decisions, and that's politically challenging, right? Communities like having the hospital there or the MOB, whatever it may be, and to take that away is, in their minds, a loss. That's fair. We see this from our quality friends and the service line leads here at Sg2. The mix of volume and quality matters. And if you can't concentrate those volumes in a meaningful way, there is a likelihood that quality begins to erode. So we need to make sure we have that trade-off. And what are we really here for is delivering high quality care. So that has to be our North Star moving forward. There's also the payer angle. The organization is saying if Medicaid is challenged and folks are becoming uninsured, can we hold out the same mix of services? If we can't do that on our own, who in the market, FQHCs, community health centers, do we need to partner with much more effectively, arm them as best we can so they can manage that population and make sure those linkages are strong as possible as patients escalate? Medicare Advantage. Trevor, I know you just put out a piece with our colleague Ryota and the churn there and saying, okay, if some folks are being impacted, having to pick new plans, what does that mean? What does Medicare Advantage want? What kind of value-oriented programs are the payers wanting to execute on? Do we need to think about our service mix differently in that realm? And then the commercial, always poking and prodding, is direct to commercial, direct to employer. The right strategy, what kind of service mix would that actually warrant? What size of employer does that account for? How do we think about new cost offsets for the employers as they try to hold out benefits? All of that also is driving some of the service mix selection.
I heard it as part of the GLP-1 discussion. Systems acknowledge and accept almost 50% reduction in bariatric surgery is really close to what most markets have seen. And most systems invested in surgeons that could do that. And they're realizing, and we have it distributed across all our sites. It's hard to plan for what all the ways GLP-1s are going to impact systems in the future. We get to and have to do it through our forecasting, but maybe harder to put it into action. Even those discussions around, well, if service is way down, we probably need to consolidate these. But I've heard planners say that's a couple years down the road until we can tackle that. It feels too tricky. They know the chess game they're going to have to play. We did a survey last year of chief strategy officers. We're talking about physician alignment. We asked how value-based care critical to where your system's going in the future. And I thought we were going to get really big distribution with only a few saying, yeah, it's really important to where we're going. 70% of them had it ranked 7 out of 10 or higher in terms of how important it was to where they were going in the future. Then the next questions were around, well, how much are you changing physician incentives and alignment? And do you have new structures you're putting in place to do that? And that was much lower. It shows how different the vision for what the future system is going to have to look like is from the places we're spending time today. Even another recent example to reinforce, we're working on a systems CIN strategy. And the health system just went through strategic planning enterprise level. And we asked, okay, well, how much is moving into downside risk and all that stuff on the table for the system? How's the CIN supposed to take that as guidance? And how are they going to grow covered lives without taking downside risk? It's not syncing. And I get it. It's tough to sync it up. But if we know we need to be in a different place down the road, how are we going to get there?
Value-based care is one of those perennial, and I've been wrestling with this for well over 10 years, and you both know. I'm on board 1 year, the next year it's like, oh, we're never going to make any headway. So this is one that I keep personally challenging myself. Where will this actually come to fruition? Let's say 75% of your payer mix is governmental, Medicare, Medicaid in some way. That's not uncommon across the Sg2 membership. And if that's true, and you're not negotiating your rates within those books of business, value might be the best way to drive additional margin. That seems to be, Trevor, in line with what your CSOs are saying. We recognize those as facts. So how do we actually move that forward? And do we do it on our own intentionally, or is it done to us by those external? It might be a mix of both, but more of it being done to us. And to demonstrate that, you can look at different data sets. If you look at an HCP land data, public-private data set tracking the path of value, within the Medicare Advantage book of business, most of those are in what they would say is the category 4, which is somewhat of a capitated or downside risk markets. And it feels like the Medicare Advantage payers are saying, hey, we're not going to give you rate bumps, but here's your value offset if you would so choose to participate in our programs. So I would say that's being done to us as providers. On the Medicare traditional side, we see a ton of activity between different programs like Teams coming out, CJRX, national mandated bundle coming through. They're saying we're going to participate in value. The time right now is a time of we need to be leaning into value-based care in an intentional way. We've had these structures on the shelf for years. The legal entity that is the CIN, with everyone signing participation agreements, and that's great and interesting. We haven't really done enough with it. It's collecting dust. We have these great meetings and nothing ever really happens. Really understanding how do we kick the tires on those and make them meaningful entities that can absorb some kind of value program across the different payer sets, types of insurance. Probably isn't a bad thing to at least start considering. Value might be next 3 to 5 years, the one shining light that we can make meaningful progress on.
This is just another example of the cognitive dissonance that we're seeing across these important realities that we are not quite ready to face as organizations. I found myself challenging several CEOs, boards, executive teams with a proposition. The business model is broken. We know that. We know things are very risky over the next several years. We'll have a choice of band-aiding, duct taping, piecing it together with bubble gum. Those are the things that we often do in this industry. Or we have a choice to be bold and to try something different and commit to some of these long-term aspirations today to differentiate yourself in the market.
Love that. Thanks for all your insights. Value-based care generally isn't in the realm of the chief strategy officer to influence and connect to broader strategy, but it's also a place where most systems stood up a leader of population health. In some ways, it's meant that it's not a top priority of the other C-suite leaders. I think we have a risk of doing the same thing to ambulatory, where we're seeing chief ambulatory officer emerge as a new title. Let's make sure that doesn't mean it's that person's problem, project, initiative, and that it stays as a strategic priority. Rebecca, Brian, thanks as always for sharing what you're seeing on the road with our listeners. Thanks for listening to this episode of Sg2 Perspectives. Please don't hesitate to reach out to Sg2 if you have questions or suggestions for future episodes.